The external and internal architecture of bone controls virtually every facet of the practice of implant dentistry. The density of available bone in an edentulous site is a determining factor in treatment planning, implant design, surgical approach, healing time, and initial progressive bone loading during prosthetic reconstruction. The quality of bone is often dependent upon the arch position. The most dense bone is usually observed in the anterior mandible, followed by the anterior maxilla posterior mandible, and the least dense bone is typically found in the posterior maxilla. Following a standard surgical and prosthetic protocol, Adele et al. Reported an approximately 10% greater success rate in the anterior mandible as compared with the anterior maxilla. Schnittmann et al. Also noted lower success rates in the posterior mandible as compared with the anterior mandible when the same protocol was followed. The highest clinical failure rates have been reported in the posterior maxilla, where the force magnitude is greater and the bone density is poorer. Bone is an organ that is able to change in relation to a number of factors, hormones, vitamins, and mechanical influences. Biomechanical parameters: duration of edentulous state, bone metabolic hormones, PTH, vitamin D, calcitonin growth hormones, somatotropin, IGF-I, IGF-2 sex steroids, testosterone, estrogen. Frost proposed a model of 4 histologic patterns for compact bone as it relates to mechanical adaptation to strain. The pathologic overload zone, mild overload zone, adapted window, and acute disuse window. Density of alveolar bone evolves as a result of mechanical deformation from microstrain. The greater the magnitude of stress applied to the bone, the greater the strain observed in the bone. 4 zones for bone related to mechanical adaptation to strain before spontaneous fracture. The acute disuse window is the lowest microstrain amount. The adapted window is an ideal physiologic loading zone. The mild overload zone causes microfracture and triggers an increase in bone remodeling, which produces more woven bone. The pathologic overload zone causes increase in fatigue fractures, remodeling, and bone resorption. 4 zones for bone related to mechanical adaptation to strain before spontaneous fracture. Acute disuse window, lowest microstrain amount. The adapted window, ideal physiologic loading zone. The mild overload zone, causes microfracture and triggers an increase in bone remodeling, which produces more woven bone. Pathologic overload zone, causes increase in fatigue fractures, remodeling, and bone resorption. The trabecular bone in a dentate mandible is more coarse. The mandible, an independent structure, is a force-absorbing element. An independent structure, when teeth are present, outer cortical bone is denser and thicker and trabecular bone is more coarse and dense. The trabecular bone of each jaw has structural variations. The trabecular bone is most dense next to the teeth, where it forms the cribriform plate. Between the teeth, the bone is usually most dense near the crest and least dense at the apex. Any strain to the maxilla is transferred by the zygomatic arch and palate away from the brain and orbit. Has a thin cortical plate and fine trabecular bone supporting the teeth. Most dense around the teeth, cribriform plate, and more dense around the teeth at the crest, compared with the regions around the apices. The dentate maxilla has a finer trabecular pattern compared with the mandible. The maxilla is a force distribution unit and is designed to protect the orbit and brain. Linko, in 1970, classified bone density into 3 categories. Class 1. This ideal bone type consists of evenly spaced trabeculae with small cancellated spaces. Class 2. The bone has slightly larger cancellated spaces with less uniformity of the osseous pattern. Class 3. Large marrow-filled spaces exist between bone trabeculae. Class 3 bone results in a loose-fitting implant. Class 2 bone was satisfactory for implants. Class 1 bone was the most ideal foundation for implant prostheses. In 1985, Lekholm and Zarb listed 4 bone qualities for the anterior region of the jaws. Quality 1 is composed of homogeneous compact bone. Quality 2 has a thick layer of cortical bone surrounding dense trabecular bone. Quality 3 has a thin layer of cortical bone surrounding dense trabecular bone of favorable strength. Quality 4 has a thin layer of cortical bone surrounding a core of low-density trabecular bone. In 1988, Misch proposed 4 bone density groups independent of the regions of the jaws. Based on macroscopic cortical and trabecular bone characteristics. D1 dense cortical oak or maple wood anterior mandible. D2 posterior mandible white pine or spruce wood anterior mandible anterior maxilla. D3 porous cortical, thin, and fine trabecular balsa wood anterior maxilla posterior mandible. D4 fine trabecular styrofoam posterior maxilla. The 4 macroscopic bone qualities are, from left to right, D1, D2, D3, and D4. D1 bone density has the greatest amount of bone implant contact. Because stress equals force divided by area, the increase in the area of contact results in a decreased amount of stress. A cross-section of a D2 mandible in the region of the mental foramen. A thick cortical plate exists on the crest and a coarse trabecular bone pattern exists within. A posterior maxilla demonstrating D3 bone with a thin porous cortical plate on the crest with fine trabecular bone underneath. In a D4 posterior maxilla, the posterior crestal region has little to no cortical bone on the crest and is composed primarily of fine trabecular bone. In a finite element analysis study of D1 and D2 bone with a division A, B, or C bone volume predicted no implant failure. B. In a finite element analysis study of D3 bone of 1/3 the strength, no failure was predicted in division of bone. C. In a finite element analysis study, D4 bone was inadequate in strength for implant success, even in division of bone volume. Division A, D1, D2100% density ultimate compression strength, 22.5 MPa no failure predicted. Division B, D3 50% density ultimate compression strength, 7.5 megapascals no failure predicted. Division C, D4 25% density ultimate compression strength 3.5 megapascals failure predicted. A range of bone loss has been observed in implants with similar load conditions. The magnitude of a prosthetic load may remain similar and give one of the following 3 different clinical situations at the bone implant interface, based on bone density. 1. Physiologic bone loads in the adapted window zone and no marginal bone loss. 2. Mild overload to pathologic overload bone loads and crestal bone loss. Or 3. Generalized pathologic overload and implant failure. Therefore, to obtain a similar clinical result in each implant prosthesis, the variables in each patient must be either eliminated or accounted for in the treatment plan. Periapical or panoramic radiographs are not very beneficial to determine bone density. Bone density may be more precisely determined by tomographic radiographs. Especially computerized tomogram, CT produces axial images of the patient's anatomy, perpendicular to the long axis of the body. Each CT axial image has 260,000 pixels, and each pixel has a CT number, Hounsfield unit, related to the density of the tissues within the pixel. In general, the higher the CT number, the denser the tissue. Modern CT scanners can resolve objects less than 0.5 mm apart. Software is available to electronically position the implant on the CT scan and evaluate to Hounsfield numbers in contact with the implant. The Misch bone density classification may be evaluated on the CT images by correlating Hounsfield units ranges. The very soft bone observed after some immaterialized bone grafts may be 50 to 200 units. D1, greater than 1250 Hounsfield units. D2, 850 to 1250 Hounsfield units D3, 350 to 850 Hounsfield units D4, 150 to 350 Hounsfield units D5, less than 150 Hounsfield units. The patient is first examined. Most common radiographic evaluation, a panoramic radiograph. The initial treatment plan is presented to the patient using the anatomical location as an index of the bone density. Anterior mandible and single tooth replacement is D2, anterior maxilla and posterior mandible is D3, and posterior maxilla is D4. Bone density treatment plan: stress equals force area decreased, bone density equals increase implant area by implant number, implant width, implant length, implant design, implant surface condition. Scientific rationale of strength, modulus of elasticity, bone implant contact percent, and stress transfer difference related to bone density has to be addressed. The bone density by location method is the first way the dentist can estimate the bone density in the implant sites to develop an initial treatment plan. Therefore, the initial treatment plan before computed tomographic, CT, radiographic scans or surgery suggests the anterior maxilla is treated as D3 bone, the posterior maxilla as D4 bone, the anterior mandible is D2 bone, and the posterior mandible is D3 bone. A more accurate determination of bone density is made with computerized tomograms before surgery or tactily during implant surgery. The bone loading process from occlusal forces becomes a critical factor in long-term implant survival. The bone density under load is directly related to the bone strength and is therefore a critical parameter for long-term survival. Must remain within the physiologic to mild overload zone, otherwise, pathologic overload with associated bone loss and microfracture, and implant mobility may occur. A traumatic bone preparation, close approximation of living bone to the biocompatible implant surface, and absence of movement at the interface during healing.